Good afternoon, everyone. Welcome and thank you so much for joining today's Healthcare Team Cyber Discussion. I am Veronica Shalett, Program Director in the National Cancer Institute's Healthcare Delivery Research Program. Today is our third and final session of our three-part series on examining diagnostic treatment delays and decreasing adherence to cancer treatment due to financial hardship. Just want everyone to know this session is being recorded. And the focus of today's session is on the current approaches for addressing medical financial hardship during cancer treatment and survivorship care. And our presenter will outline priority areas for future research. We hope that our spotlight on financial hardship will stimulate your ideas to address this issue in your area of work. We hope that you were able to read the two articles that our presenter recommended for background reading to prepare you for today's presentation. If not, no worries, you can retrieve them by putting the titles that I have in the chat box into Google and retrieving the articles that way. To prevent background noise, all lines are muted upon your presentation. So if you have questions that come to mind during your presentation, feel free to type them into the chat box and press send, and then we will read them during the Q&A timeframe. Also during the Q&A timeframe, you can also use the chat feature to ask a question, or if you want to raise your hand, select the raise hand icon under the participant panel, and we will unmute your line so that you can ask your question audibly. And if you have questions or comments at any time about this session or our series, please email us at hctcyberdiscussions@nih.gov. Closed captioning is available by selecting the media viewer panel on the right-hand side of your screen. We do have a few poll questions for you today, and we hope that you will be participating in the poll questions by going to Mentimeter at menti.com, and you'll be using the code 7574422 that you see at the top of your screen. And you can access Mentimeter by your cell phone or your computer. So with that, I'm very happy to introduce you to today's speaker, my colleague, Dr. Janet Moor. She has a lot of commitments, and I'm so grateful that she's carved out time out of her busy schedule to share her research on addressing medical financial hardship in the context of cancer care delivery with us. Dr. Moor is the Deputy Associate Director of the Healthcare Delivery Research Program, where she provides support and expertise to our Associate Director, Dr. Paul Jacobson, on developing and implementing long-term strategic goals. And she also leads many activities in our program, such as our annual budget process, communications, and scientific planning. Dr. DeMoor also leads research and programmatic activities focused on cancer-related financial hardship, as well as employment outcomes after cancer. She has provided scientific leadership to initiatives such as the National Health Interview Survey Cancer Control Supplement, the National Survey of Precision Medicine and Cancer Treatment, and the NIH Adherence Network. Dr. DeMoor is a recipient of the 2019 Cancer Epidemiology, Biomarkers, and Prevention Frederick P. Lee Impact Award. She's also received NCI Merit Awards for her work on the Medical Expenditure Panel Survey Experiences with Cancer Supplement and the Cancer Trends Progress Report. Janet, thank you so much for leading today's Healthcare Team Cyber Discussion. And I'm going to turn this over to you now.
Great. Thank you, Veronica. I'm very, very pleased to be here and to talk to you and the audience about the survey that we conducted. Next slide, please. Great. So to kick things off today, I would love to know where everyone is calling in from. So using Mentimeter, if you could please enter the code and note which city and state you're joining from today. Jennifer, does it look like people are able to access the Mentimeter?
Yes, it looks like people are able to access the Mentimeter, but for some reason the results aren't showing currently on the screen.
Okay. Are you able to see them on your end?
I'm looking to see if there was a setting that has been accidentally checked, but if not, we can move to the next slide and we'll figure it out from there.
Okay, great. Okay, great. So our second poll question to start things off today is to ask how you would describe your current role. So if you could again go to Mentimeter and enter that information. Jennifer, does it seem like it's working?
Yes. So let me,
Oh, this is great.
there we go.
Okay, oh, wonderful. Well, this is excellent. Thank you. It's great to know who's on the call. We have a lot of different positions and roles and disciplines represented here. So that's fantastic to know. So all of you are bringing something different to this presentation, which is great, and really look forward to your thoughts and questions that arise as you're listening. And I'm hopeful that we'll be able to have a discussion at the end. Looking forward to your thoughts and perspective on this topic. Okay, Jennifer, if it looks like we're ready to move on here. So thanks again for being with us today. So I have three objectives that I'd like to cover in my talk today. So the first is to briefly describe the prevalence and consequences of cancer-related financial hardship. I'll then present findings from a recent survey we conducted of the NCI designated cancer centers to better understand their the availability and delivery of financial navigation services, as well as ongoing research. And then I'll conclude by discussing some future research directions. And just so you know, there's going to be another poll at that point in the presentation. As well as to tell you about some data resources and funding opportunities for supporting research on this topic. Next slide, please. Great. So just by way of background, cancer-related financial hardship is really a multidimensional construct that comprises material conditions, the psychological response to those conditions, and coping behaviors. So just to unpack that a little bit. So when we're talking about material conditions, we're really talking about out-of-pocket expenses for medical costs. We're talking about productivity losses, losses of income and assets, medical debt, problems paying for medical bills, and in extreme cases, bankruptcy. When we're talking about the psychological response, what we're really talking about is the stress and distress and worry that results from paying medical bills or being concerned about employment changes and lost wages. And then coping behaviors include the sort of behaviors that patients and survivors adapt to manage their out-of-pocket medical costs. There's increasing evidence that cancer-related financial hardship is common, affecting upwards of half of all individuals who are diagnosed with cancer. Financial hardship is caused and exacerbated by the high launch price of new cancer therapies that tend to increase over time. new therapies are increasingly priced in excess of $100,000 a year, which again has increased and seems to be continuing to increase. Another important factor driving the experience of financial hardship is insurance benefit structures that lead to high patient out-of-pocket costs. So these costs come from sort of cost-sharing structures, co-pays, co-insurance, deductibles, all which can be very burdensome to patients. And then finally, cancer diagnosis and treatment can lead to employment limitations and can affect the ability to work. It can prompt individuals the individual patients as well as their families to take sick leave, make other employment changes, and can sometimes result in job loss, all of which can both sort of initiate and also exacerbate the experience of cancer-related financial hardship. Next slide, please. So there's been some research that is, again, attempted to document the prevalence of different aspects of financial hardship. So the graph on the left side of the slide presents some data from a paper led by Robin Yabroff and colleagues, in which they looked at data from the Medical Expenditure Panel Survey, basically characterizing the prevalence of material and psychological financial hardship associated with cancer. And what you can see from this graph is among those 18 to 64 at the time of diagnosis, about 40% experienced any psychological or material financial hardship. And I should note that that sample is comprised of a prevalent sample of cancer survivors. So most individuals were longer term survivors, yet we still see high levels of financial hardship as they reflect back on their cancer experience. There's growing evidence that financial hardship is detrimental to patients and their families. And here's where you see some of the coping responses that I alluded to in the previous slide. Patients experiencing financial hardship are more likely to delay treatment and not adhere to recommended treatment. Financial concerns affect clinical trial participation, and as previously mentioned, can lead to stress and worry and diminished quality of life. Next slide, please. So as we think about interventions to address cancer-related financial hardship, those interventions fall into 4 different buckets. So the first are policy solutions, typically around increasing competition and price transparency, also policies to expand paid sick leave. There are employer level policies. So these typically include workplace accommodations, access to paid leave, as well as other resources and supports for supporting employees with health conditions. And then there's the 2 buckets that I'm really going to focus on in my presentation today. And those are interventions at the level of the healthcare system, typically financial navigation, which includes screening for financial hardship and financial service delivery, as well as interventions with providers and targeting patient-provider communication, typically around cost communication that occurs between the healthcare team and the patient. Next slide, please. So when we think about interventions at the level of the healthcare system and also with providers or that patient-provider relationship, a number of barriers have been documented to really addressing financial hardship via those interventions that need to be addressed. So the first barrier for which there is some evidence is a lack of availability and access to financial services. Second, resources to coordinate and deliver services. So this would be on the part of staff within the healthcare system to coordinate services, which often are not centrally organized, but are sort of dispersed throughout a healthcare delivery system. So there's the coordination aspect, but also the bandwidth to deliver those services on a consistent basis. There's the rather substantial challenge of estimating what treatment will actually cost, which is an important precursor to having meaningful communication about what those costs are likely to be. There's been evidence that providers are not comfortable with discussing cost issues with patients, and there remains open questions about the staff that should be involved in those conversations, what those conversations should include, and other unanswered questions. And then finally, patients' own preferences and concerns about discussing financial issues with their healthcare providers, as well as what they need in terms of financial services and support. So some barriers, some unanswered questions, and I will say that while the literature in this area has done a very good job of sort of documenting the problem of financial hardship, the intervention literature in this area is nascent, and we're definitely at the early phase of thinking through and evaluating interventions to address cancer-related financial hardship. Next slide, please. Okay, so before I get into talking about the survey that we conducted, I wanted to ask you another question. So as I just alluded to, financial hardship is a complicated issue, and it's multidimensional in nature and really requires a suite of services to address financial need during cancer treatment. So there's a lot of services that are needed to address this complex problem. So my question for you is, which healthcare team members do you think provide financial services most frequently? And this would be providing services to individuals who are undergoing cancer treatment. So if you could please go to Mentimeter and enter your response.
And if for some reason Mentimeter is not working for you, please feel free to type in the chat your answer to this poll question.
Does it seem like it's working, Jennifer?
No, for some reason, it looks like a few of these slides are just not accepting the answers on the front end, but I am seeing them on the back end in terms of the export report.
Okay.
And it looks like a few people have chimed into the chat who are financial navigators, social workers, billing staff, patient navigators. So thank you to those who are contributing via the chat. But with that, Janet, I'd recommend we just move forward.
Okay, great. Well, thanks to those of you who were able to weigh in. We're actually going to return to this question in a few slides, but it's good to have these responses. I'll refer back to them in a minute. So in an effort to better understand the landscape of financial navigation, we conducted a survey of the NCI designated cancer centers to assess a number of different things, namely how they were screening patients for financial hardship, and really looking to describe the practices, their practices for identifying patients experiencing cancer-related financial hardship. We were also interested in service delivery and characterizing the existing financial navigation services and their mode of delivery to patients, and importantly, which staff were involved in delivering those services. And finally, we were interested in research and the number of ongoing studies, both observational and intervention studies, addressing cancer-related financial hardship. And again, we chose to field the survey to really to get a snapshot of what was happening, as well as to inform other future activities at NCI related to this topic. We also are aware that although a minority of patients are treated in NCI-designated cancer centers, these organizations tend to be very well-resourced, and it seemed, and we had a mechanism for collecting this information. So this was really a jumping off point, and we've certainly had follow-up conversations about how to capture information about what's happening in community settings as a follow-up. But this survey that I'll be talking about today was fielded only with the NCI designated cancer centers. Next slide, please. Great. So we fielded the survey between July 26th and September 9th, 2019. The survey was conducted with an online survey. Tried to keep it reasonably short. It consisted of 16 multiple choice and open-ended questions that we developed in collaboration with a number of subject matter experts. And these surveys, as I mentioned, were completed online. Eligibility for the survey was limited, as I've also said, to the comprehensive cancer centers and cancer centers that provided patient care, which for our purposes was 63 at the time of the survey. We did ultimately exclude St. Jude Children's Research Hospital from the sample due to their unique billing model, which brought the eligible population for the survey to 62 cancer centers. Next slide, please. Next slide. Great, thank you. The survey invitations were sent to the associate directors in charge of population sciences for each cancer center. In some cases, that individual completed the survey. In other cases, they recommended that somebody else within the cancer center would be better suited to respond. Although we had a single respondent who submitted the responses from each center, we know that in a number of cases that staff across the center collaborated on pulling together this information. Centers received an initial invitation to participate. They could have received up to 4 email reminders and 1 reminder telephone call. And here you can see the timeline for those touch points, as well as how the number of surveys kind of increased over time in response to these different contacts. And ultimately, the survey was completed by 92%, which was 57 of the eligible cancer centers. Next slide, please. So as I said, the first sort of topic we were interested in had to do with screening. And what we found is that 95% of cancer centers had a system or process to identify patients experiencing financial hardship. This was done most frequently through using a distress screening tool or a social work evaluation. But you can see on this slide some of the other methods that were used, with about half of centers reporting using the EHR, a patient intake form, or clinic team forms. And I'll say that 81% of cancer centers had 3 or more methods to identify patients experiencing financial hardship. So this happens nearly universally, that centers are able to have a system in place to do this. Next slide, please. We also found that 82% of cancer centers proactively communicate the availability of financial navigation services. And this happens most frequently by a social worker. Also very commonly occurs by having providers sort of verbally communicate the availability of these services to their patients. 81% of centers reported that this information is on their hospital website. 51% reported that they provide this information via written materials, and then a smaller percentage, around 30%, communicate via the patient portal or through email. It's worth noting that nearly all of the centers who proactively communicated the availability of services did did this by multiple methods. So 89% used 3 or more methods to communicate financial services. Next slide, please. Great. So the second thing that we were very interested in had to do with what services were available and how they were delivered. So I apologize. I know this table is a little bit busy, and I'll apologize in advance because the next slide also has an equally busy table. But I wanted to share this level of detail so you could see not only the percentage of centers that offered each service, but also the staff that were involved in providing those services. So as you can see, you were right on in your responses. So financial navigators, social workers, patient navigators are all heavily involved in providing financial services to patients. So let me just sort of explicitly orient you to this table before I say more. So on the left side of the table, you see a set of financial navigation services that we asked about, and on this slide are those that are nearly universally available. Here you can see the percentage of centers that offered each service. And on this slide, all of these services were offered by 95% or more cancer centers. So that includes help applying for pharmaceutical assistance programs and medication discounts, help applying for financial assistance with non-medical costs, referrals to a foundation or charity for financial navigation, or to help paying for medical care, and then also help applying for health insurance coverage, including emergency Medicaid. On the right side of the graph, you see the staff who most often provided this service. And what we did with what you're seeing here are the staff, so it was basically the top 3 staff positions that were mentioned most frequently for each of these services. So, and if you look at the percentage of centers that mentioned each, you'll see that, in the case of help applying for financial assistance with non-medical costs, in almost every center that's done through a social worker, but followed by a financial navigator and a patient navigator, although in each of those cases, only about 30% of centers used those staff to provide this particular service. I hope that's clear. But again, I think the take home from this slide and the next one that I will talk about is that a range of financial services are available within the cancer centers, and that they are largely delivered by social workers and financial navigators. Next slide, please. So whereas the services on the previous slide were nearly universally available, on this slide you see other financial services that, although reasonably widely available, availability is a bit more variable. So if we kind of go down the list here, we see that help understanding medical bills and out-of-pocket costs, or the projections of what those costs are expected to be, were offered by 89% of centers. Also very common are to provide direct financial assistance with non-medical costs, such as transportation, utility bills, housing, and other expenses, and direct financial assistance paying for medical care, including the costs associated with a clinical trial. So, north of 80% of centers offer those 3 services. The services that were offered least frequently include counseling about medical debt management, having detailed discussion about treatment options, including a comparison of costs, and then finally providing guidance about legal protections for cancer patients and their families. Although here again, when you look at the staff who are involved, we see a lot of consistency across services and the staff that tend to provide those services. There are some differences, but by and large, it's really social workers and financial navigators who tend to be the most heavily involved. Next slide, please. Great. So in addition to asking about the services that were available, we were very interested in centers' experience in delivering financial navigation services. So on this slide, as well as the next slide, you'll see we asked about sort of a range of different experiences, and then asked centers about to what extent they agreed or disagreed with these different questions or these different statements. So you can see that 72% of centers strongly agreed or agreed that it is difficult to determine how much a cancer patient's treatment will cost. 70% agreed or strongly agreed that oncologists are reluctant to discuss financial issues with cancer patients. 67% strongly agreed or agreed that the applications for financial assistance are complex and time-consuming. And 54% of centers strongly agreed or agreed that cancer patients were reluctant to ask for help when they needed it. Next slide, please. Now, in this slide, you see experiences where, again, the experience across centers was a bit more variable. So 46% of centers strongly agreed or agreed that the pathways or workflows to connect cancer patients with existing financial services are unclear. About 44% agreed or strongly agreed staff did not have time or capacity to coordinate financial navigation services for cancer patients. However, 38% of centers disagreed or strongly disagreed with that statement. 40% strongly agreed or agreed that there are few financial navigation services available to offer to cancer patients, whereas 49% of centers disagreed or strongly disagreed with that statement. Oh, hello? Oh, sorry. Thought someone said something. Moving on, 40% of centers said there was a lack of staff awareness about available financial navigation services, whereas 44% disagreed or strongly disagreed with that statement. And then finally, 39% of centers strongly agreed or agreed that staff were not equipped to discuss financial issues with cancer patients, whereas 38% disagreed or strongly disagreed with that statement. So I think, again, the take-home message from these slides is that centers really vary in their experience delivering financial navigation services. Next slide, please. Now, the third topic that we were interested in capturing with the survey had to do with research. And what we found is that cancer centers report ongoing research to understand and address cancer-related financial hardship. And many centers had active observational or intervention studies of cancer-related financial hardship. And it's important to note that 30% of centers reported that they had new research studies in development to either understand or address patients' financial needs. So here you can see the breakdown of those data. 45% of centers reported that they had one or more active observational studies, and 26% had one or more intervention studies that were currently ongoing. And I think that these numbers are probably underestimating the amount of ongoing work. You can see that the percentage of respondents who said they didn't know how many studies were active for observational, really for both, was pretty high. So I don't think that this is really fully capturing the scope of research, ongoing research on this topic. So that's something we'll need to dig into a little bit deeper. Next slide, please. Great. So I want to mention just a few limitations of this project before going through the conclusion. So it's important to know that these data are from the perspective of respondents. That's of course the case with every survey, but you know, again, the delivery of financial services occurs by many different staff, and these services tend to live in different places across the cancer center. So we are seeing a snapshot from the perspective of the person who answered the survey. We did not independently verify the information that was provided. So that's just important to keep in mind. Also, the findings are based on self-report. Again, as I said, we didn't attempt to verify the existence of we didn't attempt to verify any of the data. The survey did not capture financial navigation from the patient's perspective, so we don't know. We know what's available, but not necessarily what was used and how useful patients find these different services, or how easy they are to access. So that's definitely an area for future research. As well as other work to sort of delve more deeply into the patient's perspective. Next slide, please. Great. So I think these data point to a number of conclusions, or rather, we can draw a number of conclusions from these data. So the first is that within the NCI designated cancer centers, financial services are available. I think that the survey suggests that there's many tools to identify patients experiencing financial hardship and to address financial needs. However, experiences differ across centers. We see really widely different experiences in delivering financial navigation services. And this is likely due to the services that they offer, available infrastructure, staff and staffing resources, as well as existing workflows for delivering different financial services. I think it's pretty clear that care coordination is a challenge. We see that services are delivered by a multidisciplinary group of staff. However, awareness of services and the capacity to coordinate services is an issue for some centers. And finally, additional research is needed. I would argue that a pipeline of research is needed to mitigate cancer-related financial hardship, to develop models of financial service delivery, and improve care coordination and the delivery of financial services. Next slide, please. So based on these conclusions and your own experience with this topic and reaction to the survey data, I would love to hear from you about the topics that you think future research should address in order to decrease medical financial hardship. This is a topic that, this is a topic that's received attention in the scientific literature. It's been well documented in the popular press. And I know has affected many of us in a very personal way. So again, would love your thoughts. So please go to menti.com and you see the code there at the top of the slide. And hopefully we can capture some ideas here. But I see two already, which is great. So looking at financial hardship issues for patients receiving care outside of National Comprehensive Cancer Centers, absolutely. An excellent suggestion. And then also looking at policy changes, reducing costs, and the enforcement of disability accommodations are key. Completely agree. So it looks like two people have weighed in thus far, although it could be that there's a bit of a lag here. So we'll just, we'll give folks a few additional minutes here to weigh in with any thoughts.
And again, if Mentimeter is not working for you, please feel free to use the WebEx chat. I know I see someone typed in policy implementation research as one of those areas to focus on.
We'll give this one more minute. Okay, Jennifer, I see that 2 people have responded. Are you seeing any more responses on your end?
No, it kind of looks like the screen may have froze on the Mentimeter's end, but I also see someone else has typed in the chat, effect of different insurance models on hardship as being one of those topics for future research.
Excellent, thank you. Well, thanks to everyone who weighed in. If you have additional ideas, please feel free to put them in the chat. I would definitely agree with those ideas that have been raised, and I think they speak to a need for sort of continuing to document the problem, especially in different settings, as well as the importance of policies and interventions at other levels to be addressing this problem. There's absolutely more work that needs to be done. And it's something that we've talked about a fair bit with sort of our internal group that's working on this topic, is the whole cost communication issue and the different pieces involved in that, and then thinking about a research agenda. Oh, look at this, wonderful. Great. Yeah, so again, wonderful. Yeah, so seeing some of those themes, the importance of policy, thinking about populations who are vulnerable to financial hardship. That's really key. I mean, I think that we're finding that even individuals who are well insured, coming to people who have health insurance who are diagnosed with cancer end up being underinsured. So when we're thinking about this problem, it's not just an issue for individuals who are uninsured or uninsured, but really affects patients quite broadly. That said, people who come to their cancer diagnosis with existing financial difficulty or struggles are particularly vulnerable to sort of further exacerbation of those troubles as they go through as they're diagnosed and go through treatment. Wonderful. So, I mean, lots of great ideas here, and really identifying some important directions for future research. So I want to make sure we end with a discussion of some data resources and also some funding opportunities that you may or may not be aware of that can be used to support research on this important topic. So Jennifer, maybe we can move on. Great. So in the last couple of slides, I've listed some different surveys and other resources that can be used to support research on cancer-related financial hardship. I won't go through each of these in detail right now, but did want to list them and also note where you can go for more information. So all of these resources are available or listed with more information on the NCI's Healthcare Delivery Research Program's website. The URL here is at the top of the page. And there you can find additional information about these surveys. So there are population-based household surveys, namely the HINTS, the Medical Expenditure Panel Survey, and the National Health Interview Survey. While not necessarily focused on this topic, do include questions about employment, about income, about financial need, about delaying or foregoing recommended care in the case of the MEPS and the National Health Interview Survey. So they can all be used to explore questions around financial hardship. Also, I want to note that these surveys, because they are general household surveys, in the case of HINTS, NHIS, and the core MEPS, they include both individuals with a history of cancer as well as individuals without a history of cancer. So that really opens up an opportunity to do some interesting comparative research where you're looking at the experience of cancer survivors as that experience compares to the general population. We also have support a number of data linkages, namely claims data linkages with our SEER data. So there's SEER Medicare and SEER Medicaid. Both SEER Medicare has been widely used to look at issues of cost. SEER Medicaid is a new data linkage, but in both cases, there's additional information on our website. And then we have data on cancer care in community settings through our NCI Community Oncology Research Program. And again, more information about that program and its activities is available on our website. Next slide, please. Great. Funding opportunities. So here again, I've listed some places where you can go to find information about current funding opportunities. So these include our parent funding announcements, which can be used to support sort of a broad array of research questions, as well as targeted funding opportunities. And here again, although there might not be specific funding opportunities that call out financial hardship by name, we have a number of mechanisms that are sufficiently flexible and are widely used to support research on this topic. I also wanted to make sure that you were aware of our SBIR and FTTR program, which are used to support grants from small businesses. Again, the URL is there where you can go for more information. As well as the general address to the NIH guide for grants and contracts, which is a great resource if you're looking for funding opportunities to support your research. Next slide, please. So you don't need to go it alone. Our program is full of people who can guide you through the process and answer questions about this topic, but also funding opportunities at NCI more generally. So this is the staff of the Healthcare Delivery Research Program. And here again, if you go to our website, you'll be able to find a bio and contact information for all of these individuals. This group includes many program directors, again, who can help navigate the process of applying for grant funding, as well as answer other questions that you may have. You're also welcome to contact me directly if you have questions about this presentation or would like to discuss research ideas on this topic. So we are here to help. You don't need to go it alone. Next slide, please. Great, and I just want to acknowledge the people who were involved in putting together the survey. So namely our NCI Office of Cancer Centers, led by Henry C. Lino. We have an internal financial hardship working group who was very involved. Our contractor was ICF, and the survey was led by Emily Brennan. And then we had a group of NCI advisors, as well as some external advisors who helped us come up with the survey questions for this project. And next slide, I think that's the last one. Great. So happy for your questions. And Veronica, I think you have another slide in here with information about a specific.
Yes, first of all, thank you so much, Janet. This was a wonderful presentation. Appreciate you sharing the research that you conducted on financial hardship in NCI designated cancer centers, and particularly for sharing so many useful resources and initiatives and links relative to how our participants can continue to explore additional questions around financial hardship. So thank you for sharing those resources with our participants. We do have time for a few questions. If anyone has questions, you can enter them into this chat box, or you can raise your hand and we can unmute your line. Also, as Dr. Moor mentioned, you can contact her directly if you have questions that you think of after this session ends. So I'll give a few seconds to see if there's any questions that come through before we move forward. Are there any specific RFAs that you could discuss in this area that we should think about targeting? That's one question that came in, Janet.
So, right now we do not have a specific kind of targeted RFA or other funding opportunity for this topic, but many investigators who've been doing work in this area have applied to our modular R01, which is a smaller R01 mechanism. It has a modular budget, so it's a little bit of a smaller budget. That mechanism has been used by a number of investigators who have both collected, who have done sort of prospective data collection, but that's also been used to support some novel data linkages or secondary data analyses to look at questions in this area. We've also had people apply to our other parent mechanism. So that would be the parent R01, either for clinical trials or that does not allow clinical trials, as well as our parent R03. So right now we have those more general mechanisms. But we also have on our website a list of more sort of targeted program announcements and NOCs, notices of special interest in different areas. And like I said, while not explicitly calling out financial hardship, it could be that there is a question that could be asked that would be responsive to that, to that funding opportunity, one of those funding opportunities that also addresses a question related to financial hardship. I will say too.
Go ahead.
About that. We've funded some administrative supplements on this topic. So these are funded investigators who have requested supplemental funds to an existing NIH grant to study aspects of financial hardship. And we have funded a few looking at where the investigators have added questions about employment limitations to an ongoing grant to study cancer-related employment outcomes, as well as investigators who have explored how to look at other financial hardship questions. So that's an option as well.
Great. Thanks again for your response to those questions, Janet. I also had one comment, and that was that I was wondering how the survey responses to the work that you did in cancer centers, how does that align with financial services offered by other health systems?
It's one that we can't answer exactly with our data. But I will say there is an interest in there is interest in answering that question, getting a handle on if what we see within the NCI designated cancer centers translates to community settings. I will say in the process of putting the survey together and thinking through the questions, we did work closely with that panel of external advisors that I mentioned. Some of whom are not based at NCI cancer centers, are based in other settings. And I mean, anecdotally, it seems like there's a fair bit of consistency in what's offered. But I'd say that's an important question that should be explored, not only what's available, but also the related questions of, what's available, what percentage of patients in need have access to those services, how useful do they find them? These are questions that need to be asked broadly.
Thanks, Janet. Well, we're almost at the top of the hour. Can you advance the next slide, Jennifer? I just want to share with our participants that we also have another funding opportunity that we would like to share with you. If you're interested in conducting research on healthcare teams and coordination, we have the notice NOTCA 19059, and this invites investigator-initiated research applications that are focused on understanding and improving professional teamwork and coordination during cancer diagnosis and treatment. So if that interests you, we would love to hear from you. Please reach out to contact either Dr. Sally Weaver or myself, and our contact information is at the bottom of this slide. So there are more questions in Google Docs, but I don't think we have time to answer those. So Janet, I'll send those to you, and then we can probably reach out to the participants with the responses after this session ends. So next slide. Just want to introduce our next series that begins in October. We don't have a firm date on the October session yet, but feel free to register for the other sessions that will be in 2021, and the registration link is listed at the bottom of this slide. So we're going to end a little bit early so that you can attend your next meeting on time and also have time to fill out our online evaluation. We really appreciate your feedback because it helps us improve our future cyber discussion. So if you could please take a few minutes and fill out the online evaluation, we would appreciate it. Thank you, Janet. Thank you to all the participants who participated in the Mentimeter. Sorry that we had some technical issues with that, but we really appreciate your presence today in this call, and we hope you enjoy the rest of your day. Thank you.